Welcome commissioners and members of the public to this meeting. This is another remote-only meeting of the Maryland Healthcare Commission. Given the remote-only format, additional ground rules will apply. I'll begin the meeting with a roll call of the commissioners. During the meeting, I ask that people who are speaking identify themselves before they speak. That way the commissioners and members of the public will know who's speaking. We'll have the same knowledge as if we were together in the meeting room. We're going to use the Zoom meeting format today. As we can see, all commissioners are unmuted and may speak. Public and most staff should self-mute and may not speak unless recognized by me. Due to the possibility of a background noise, I ask that commissioners and others mute their phones when they are not speaking. For this meeting and at future remote-only meetings, we will be posting documents that will be acted on or discussed at least a day in advance so that members of the public will have time to download them before the meeting begins. We'll continue to provide advance notice of how to register for and dial into or log into these meetings by posting that information on the Commission website homepage and on our various social media challenges. I will now call the roll. Dr. Akintate. Bim, I saw you earlier. Are you there?
Not seeing him on the list right now.
Okay. Dr. Bhandari, I see you. Got it. Dr. Boyer.
Here,
Mr.
I'm
Boyer?
not a doctor.
It's okay. Sorry for the offense.
I appreciate it. Thank you.
Commissioner Boyle.
I'm here, thank you.
Commissioner Brumbaugh.
You might have missed me, Commissioner Akintate.
I did. I called you. We didn't hear you respond.
Yeah, I was having issues with my computer. Sorry about that.
It's okay. Commissioner Brumbaugh. Do we see her?
Not seeing right now.
Okay. Commissioner Dordan, I see you.
Here.
Commissioner McCarthy.
Not seeing right now.
Okay. Commissioner Metz, not yet.
Yeah, I'm here, Andy.
There you are. Welcome.
Thank you.
Dr. O'Connor.
Here.
Dr. O'Grady. Mike, saw him before.
He has not gotten back on this one yet.
Not back yet.
Commissioner McCarthy is attached.
Excellent.
I see his name.
Hey, good afternoon.
Welcome, Jason. Let's see, where was I on the list? Commissioner Reimer,
I'm here.
welcome. Vice Chair Sargent,
Yes, sir, I'm here.
great. Dr. Thomas. Stephen, make it back.
Yeah, he is on. I'm
Excellent.
not sure, but he's on.
Dr. Thomas, you're muted. Well, he's online there. And Commissioner Wang.
Here.
Anybody I failed to call?
Yep, this is Mike O'Grady.
Yep, we called you.
Sorry, slow getting on,
It's okay. Welcome.
but thank you.
Anybody else? All right, very good. Next agenda item, the first agenda item is approval of the minutes. So included in your packets are copies of the minutes from the December 17th public meeting of the Commission that took place via video conference. I will now entertain a motion to approve the minutes of the Commission meeting.
So moved, O'Connor.
Second, Boyle.
Commissioner O'Connor and second Commissioner Boyle. Any discussion? Hearing none, all in favor?
Aye.
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 Any
Aye.
opposed? The ayes have it. Very good. Agenda item number 2, update of activities. Commissioners have received written updates from our centers. Commissioners, do you have any questions on the written updates?
So I have one question this is Commissioner Bhandari, one question for Mr. Stefan. So about MHCC website, where the cost and other information, how we disperse this information to the consumers? Because I see, the number of consumers on the website fluctuate, and how we can spread to the more number of people or consumers?
Thank you, Dr. Bhandari. That's a challenge that we've wrestled with, and the issue is not one unique to the Healthcare Commission. Both public and private are purveyors of price transparency information. You face this challenge. We are spending a small amount of money with a private group to raise awareness. That's the Hatcher Group. That's approximately $50,000 contract with them. We are also working with the Maryland Public Television's ad agency to develop a broader initiative on engaging patients on awareness of our price and quality information. We have not reached an agreement with them. It would be under a type of vehicle called an interagency agreement, which is allows agencies to establish more easily than contracts arrangements to work together. The Maryland Public Television is, of course, heavily engaged in a number of public health and outreach efforts related to not only COVID, but HIV. And we're assessing whether they'll be able to take on this additional initiative. But right now, our intent is to establish an agreement with them to going forward. It will focus mostly on the quality initiatives, but will also be raising awareness on transparency, as well as longer term some of our telehealth activities. As you know, beginning January 1, healthcare organizations, including health systems and payers, are required to provide additional information. We are monitoring the rollout of those efforts as well. And I think in this case, the fact that there's more information out there is speaks that their interest will rise. But what we see so far is, in those efforts, it's a bit spotty, but still very early. We're going to be working with some national experts on transparency to identify ways in which we could perhaps work together with others to raise awareness. It's, as I've said many times, price and quality transparency is not as easy as other types of consumer engagement. People don't buy healthcare like they buy shoes, and working with consumers where they are means that we have to really have a gradated approach and providing different levels of information to different constituencies.
Thank you so much. You took words out of my mouth. I was going to ask you, is it possible for hospitals to disseminate that information, as well as payers, insurance companies to disseminate the information? Because insurance companies have clients, and same as the hospital, the patients, they go there. So is it possible they can have a link from their website to Healthcare Commission, or insurance company can provide that information? That's a good question for Chair Dr. Pollack and Vice Chair Mr. Sargent.
So I think some health systems do have a link already. We have not reconfirmed that with any hospital, I believe, since their obligations to post information on their own site. But let us get back to you on what the status is on those initiatives. Both payers and providers are responsible for doing this. What payers will tell you is that they think that because they have network arrangements, that the information they have pertaining to the prices or the cost that their enrollees would experience would be better than the information that the Healthcare Commission posts, because we're looking at more broadly than an individual payer. We post information for all of the commercial market, which may not be exactly reflective of any specific payer. It would be average. So I think there's some benefit to both approaches. Sometimes consumers are interested in the range that the Healthcare Commission would have. But if you want to know specifically what you're going to have to pay, it's always better for a consumer to go to the insurance carrier or their employer has purchased coverage.
Those are very important points. The insurance carriers vary tremendously, and insurance products vary tremendously in terms of what the patient's obligation is going to be overall, and potentially as a percentage of the total expenditure. The other thing that's important to keep in mind is that the data is limited to commercial payers and the commercial market. So if you're looking at some of these episodes like joint replacement, for example, that's a small portion of the overall population receiving joint replacement, because the Medicare population is so big in that group, and this doesn't measure the Medicare population at all. The information is directional. It's not absolute, and its ability to apply to any individual is more limited. That said, I think you'll find that health systems that that appear positively in the data are more likely to link to it than health systems that appear negatively. And I don't know that we certainly can't force them to link to it.
One quick
Hello.
comment. Commissioner O'Connor, isn't that number artificially linked to GBR money, i.e. volumes?
Well, the number is linked to the cost, to the charge that the patient receives, which is necessarily related to GBR and volumes. So as to Commissioner O'Connor's point, as a hospital's volume in any year goes up, its charge per patient goes down. So for that given year, the charges would be different than in a year when its volumes were lower versus higher. But it's still a reflection of what the patient experiences in that episode of care, regardless of the volume.
But aren't patients looking for cost of care, so they don't understand what you just described, right?
Well, they're looking for is cost of care, and that's what this shows. The cost that they experience. Yes, it's influenced by the hospital's volume and the hospital's GBR rate. That creates the number, but it's the number that the patient experienced at that point in time. So,
if I could add, Dr. Pollack, in response to Commissioner O'Connor's question, that HSCRC permits a hospital to fluctuate plus or minus their GBR by 5%, and with commission approval 10%. So it's not wildly fluctuating over the course of a year, where let's keep it at hip replacements or knee replacements. One day it's 10,000, and the next a month later it's 15,000. There would be some fluctuation based on managing that overall GBR, but it's not what I would call precipitous. Later today, you're going to get a presentation on variations in episodes over time. And what I think you're going to see is that in general, higher cost hospitals were higher cost rather consistently, and lower cost hospitals were lower cost rather consistency. That trends over time do vary, and in some instances they're quite positive, but the relative position of health systems has not changed dramatically over the last few years. There are always going to be exceptions, but the nature of the GBRs kind of dictate that, even though increasingly our companions across the way have more policy levers to put additional pressure on high-cost GBR hospitals to get better control of their budgets.
Other questions?
I just had a comment. This is Commissioner Sargent in follow-up to Commissioner Bandari's question. I don't see any reason why, though, the MHCC staff wouldn't have a outreach discussion with providers. It's probably a link on the site is probably not what, I'm sorry, payers. It's probably not what they would do with this information, just because there's so many different people that wouldn't affect it with the site and customer experience and a million things I'm not qualified to talk about. But it seems like there are ways that they may be interested in making this data available to subsets of their population or a communication or things like that, or making it available to providers, right, within their networks or things like that. So I don't see any harm in reaching out and making sure the payer community is aware. I think on our side, Care First has in some of its programs uses the same underlying, way of developing the episodes of care systems and is aware of it. But it seems like an ongoing discussion as we build something. How can we make it available and seek ways to have the community use it?
Thank you, and I think that's a very valid point.
Dr. Pollak?
Commissioner Grady?
Yeah, I just wanted to say, as I got to the back of the report, the Leapfrog hospital safety grades were quite pleasantly shocking. I think we had gone through a lot of hand-wringing a few years ago when we saw how poorly Maryland hospitals had done. And it looks like they've done, unless the staff is going to tell us about manipulation of data or something like that, it looks like they've really cleaned up their acts considerably. These are quite nice results coming out of Leapfrog. I just didn't know, we haven't kind of really talked, I know we're all very busy with COVID, but this is quite a nice result unless I'm missing something.
Yeah, I would venture to say that it's not quite as shocking as cleaning up their act. I think that there is some level of reporting reporting changes and focus changes that occur as you recognize the importance of a certain data set and you build your safety efforts around a certain data set. And there's no question that when you focus on one scoring system versus another, you move the needle with regard to which patient safety metrics and which outcomes and complication metrics you are most focused on and most attentive to. Leapfrog is a little bit harder to game that way because it represents such a broad swath of things, but it's not impossible. So it's not as harsh as cleaning up their act, but it is progress in the right direction.
Good. All right, thank you.
Ben, other comments?
Yes, Dr. Pollak, I don't know if you had anything to add on your view on the COVID status, but I had a couple points. I know you mentioned it earlier, but many of the commissioners weren't on. Anything more that you want to add before I make it?
I would just add that I think that, this is Andy Pollack's view of the COVID situation, influenced by or informed by the state's daily reporting and by the University of Maryland Medical System's experience. But I think that we are, for the past 2 weeks now, we've seen a progressive decrease in the positivity rate as reported by the state, down to 7.66% today. This is a leading indicator, I think, of what we can expect to see with regard to hospitalization and illness over the coming weeks. The other things that are out there that could influence that number substantially are the new COVID strain that is far more infectious and will likely at some point result in another increase in the positivity rate that we see. The predictive modeling that I have looked at, both nationally and locally, would suggest that we are likely to see relatively high numbers of hospitalizations and relatively high stress on the healthcare system through approximately mid to late March, but that after that things start to get looking better. That assumes the current levels of social distancing and masking stay in place. And it assumes that we make progress with regard to progressive vaccination of the population. But the short-term good news is real. Our total statewide hospitalization number is just north of 1,800 today, down from very close to 2,000 a couple of weeks ago. I feel good about the numbers this morning.
And what I would add is, although we still see relatively high occupancy levels in hospitals, what's driving that is the non-COVID cases, which in general is probably a positive thing, as most systems are now able to operate effectively without tremendous panic at close to 88 to 90% occupancy, which again is not necessarily driven by higher volumes of COVID cases, but rather the fact that non-COVID patients are able to get care, which is a good message to the public that if you're sick, you should not be fearful about going to a hospital because you would catch something else, but rather it's the appropriate place to be treated. And I think the questions that we get here kind of randomly are when we're going to get vaccines. What we know is that the state has been getting on a day by day, week by week basis, about 72,000 vaccines. They've been distributed to health systems through CVS and Walgreens to long-term care facilities, principally nursing homes and now increasingly assisted living centers, and the county health officers. The distribution of vaccines is going to be probably stable for a while, unfortunately, which means demand will outpace supply. And I think the governor and his team is trying to be very thoughtful on how the next phase of vaccines might be distributed. There's certainly far more vaccine being taken in the Baltimore metro area than in the national capital area up to this point, partially a function of the fact that our biggest health systems are all situated in the Baltimore metropolitan area as opposed to Prince George's and Montgomery, Southern Maryland. I think that's going to catch up, but we also have to be aware that in Prince George's County, only about 1.5% of the population has gotten the vaccine, and efforts to reach populations of color are going to have to be elevated in terms of those initiatives. Otherwise, the gaps are going to broaden. Certainly things such as requiring patients or requiring people who get vaccines to be in the county in which they're receiving the vaccine, I think is one thing that probably should be considered if it's not. Otherwise, people who are maybe more technology savvy can county jump and decide can grab a vaccine at a county in which they don't live. But I think there's awareness of that, and we clearly want to move forward with those efforts, even as we recognize that the vaccines will be in short supply. I also just wanted to touch on an issue of at the national level, which was I believe it was December 27th, then President Trump signed what was called the stimulus bill. It's actually 12 appropriation bills and the coronavirus next coronavirus stimulus package. In that bill had some pretty important provisions for the Healthcare Commission. One that we had been engaged in for many years was work on surprise billing. It does look as though at the national level, we are going to be moving towards a national solution to surprise billing. A lot of work is going to have to be put forward as that bill will become, payers and providers have to be ready for that to take effect January 1, 2022. We have not been as active in Maryland because we, along with stakeholders, worked collaboratively in the 2011 to 2013 period. Then Executive Director Cowdery and I were very active in trying to reach a fair solution that has not been perfect, but has stood the test of time. But we'll be looking at, as the national program rolls out, what else might be done in Maryland. Secondly, and maybe more importantly, and I'm sure that Commissioner O'Grady is paying attention to this, there's significantly new funding for the deployment of APCDs, and we have already been meeting with colleagues from across the states, convened by NATO, and supported by our PMO, Friedman, in planning for accessing funds over a period of 3 years. States will be able to access up to $2.5 million per state. There are going to be incentives in this program for states working together to build multi-state initiatives, which we've strongly endorsed. What we plan to do is really work with our provider and payer communities to get their input on how as well as state agencies, on how this $2.5 million might be wisely spent and used to benefit, first off, of course, consumers, but also state policymakers and the provider and payer community as well. So it's a really positive step, and there are now 21 states with APCDs, including our colleagues in Virginia. We would expect that this is going to really incent the establishment of APCDs across the country now with this additional funding. So we're very hopeful, and I look forward to working with the commissioners that are interested in these initiatives and carrying it forward. Finally, to that end, we had planned to launch our recompetition for our APCD contract early this spring because of the bulk of contracts that are being considered by our partners in state government. The oversight agency is now General Services and Department of General Services. We haven't been able to move that procurement forward as quickly as possible, but they are working to approve it. In the meantime, we decided it would be for the best interest of the commission and the data collection effort to extend our existing contract with Social and Scientific Systems through the end of this year. That would cover the bridge period between the existing contract and the new contract, and allow this to continue seamlessly going forward. There's going to be a lot of challenges with the APCDs, but we have some really enthusiastic organizations that are interested in competing for this. We also have close collaborations with CRIS, for instance, and our partners at HSCRC, who see very creative uses of the data moving forward. So after many years, Maryland has been a leader. We think that over the next couple of years, we're going to really step out in front, including building linkages to administrative data through collection through the electronic health networks to populate the APCD, as well as working with CRIS and provider partners to really develop the strong provider directories that are key to understanding the operation of provider organizations in working with payers. So with that, I'm very hopeful, and I really appreciate all the staff that have been really focused on this over the last several months.
Very good. Thank you. Additional questions for Ben? Before we consider action items today, I want to remind commissioners.
I'm sorry, I was on mute. Do you mind if I have one question?
Oh, go ahead.
I didn't hear it, Ben, but is there anything with the change of administration, is there anything on the burner with respect to the ERISA issue and all payer claims databases?
Yes.
At the federal level?
And thank you for prodding me on that in the stimulus bill. There is directives for Department of Labor to develop a common data format that would be used by ERISA plans. It's not mandated that ERISA plans submit. DOL would have to establish that by rule, but it is a very positive step, I think, moving forward to bring back the participation of employers that are protected under the Employment Retirement Income Security Act, which exempts these employers from oversight of state insurance regulation. I think it was a stretch on the part of the Supreme Court, but it is the law of the land now, and it's a hopeful sign, although I don't think it's going to be a complete answer. We're going to have to see how aggressively DOL moves forward on this front. Certainly, all the state APCDs are going to be pushing DOL to move forward, but they likely have many things on their plate.
Just as a follow-on, I assume that it's not as steep a hill with the OPM situation about getting the federal employees back in?
I was going to wait with 1 week before I reached out to our colleagues at OPM to see if anything had changed. We have a consulting agreement with a former director of health programs at OPM. So we have good intelligence on what is feasible. But as I understand it, the director of federal health programs, which is a career appointment, as you probably know, Commissioner O'Grady, but others may not. So she will be retaining her position, but certainly the political leadership will have changed. So thank you for raising that issue, and that's an important data gap for us, certainly here.
Good luck.
Chairman Pollack?
Yes.
This is Teresa. I have 2 updates as well, if now is the appropriate time.
Sure.
The first update is I'd just like to introduce the newest member of our quality team, and that is Diana Estrada Alamo. Diana has over 5 years experience in healthcare and recently graduated with a master's in public health from Yale University. And prior to that, she received her BA, earned her BA from the University of Pennsylvania. She also holds a professional certificate in data science from Harvard University. And she will be taking on the lead in terms of our new health disparities initiative, which includes expanding reporting on the website, as well as strengthening our relationships with the Office of Minority Health and other agencies. So I would just like to ask the commission to join me in welcoming Diana to the commission.
Welcome, Diana. It's a pleasure to have you here.
Thank you so much.
And I have a second brief update as well.
Yep.
And I'd just like to extend appreciation for the extensive discussion that was held last month on the redesign of the website. It was very helpful for the staff. In response to some of the feedback, we're making some additional changes to the website. We will be expanding the physician information to include other provider categories in response to Commissioner Akintadi's comments. And Commissioner Boyle, we have confirmed that the new website will be mobile ready using the most current technology available. And finally, after a lengthy discussion on the display of race and ethnicity, the staff has done some review of other state, internal state agency websites and information that's provided. And we find no compelling reason not to display simple race and ethnicity descriptive information on the profile pages of nursing homes and other facilities for which we have that data. So our plan is to include that on the new website, and we will also look at that relationship and correlation between race and performance on the various quality metrics as suggested by Dr. Thomas. So I wanted to share that update with you, and also in follow-up to earlier conversation, when we updated the website 5 years ago, we did in fact reach out to hospitals and providers and payers, and we do plan to do that again, but we're holding off until the website is redesigned and complete and released, and our goal is now the 1st of March. So that is our plan to do that as well.
And Mr. Chairman, this is David Sharp. I too have an addition to the update.
Okay.
Good afternoon, commissioners. I would like to introduce Kelly Scott to the commission. Kelly joined MHCC on January 13th as a program manager in the Center for Health Information Technology and Innovative Care Delivery, working in the Health Information Technology Division. Kelly comes to us from Medical Decisions Logic, Inc., a medical software development organization where she worked on projects related to health information exchange, electronic health records, and value-based care delivery. In addition, Kelly has taught English at the college level and was a small business owner of a tavern in Baltimore City. Kelly holds a master's degree in fine arts and lives in Baltimore City. Mr. Chairman, commissioners, this concludes my addition to the update, and please join me in welcoming Kelly. And I believe you can see Kelly if you scroll down. She is on camera with us now.
Welcome, Kelly. Look forward to having you.
Thank you. Thank you. I'm happy to be here.
Do other center directors have updates? Hearing none. Before we consider action items today, I want to remind commissioners that if they wish to recuse themselves on any action item, they should inform the chair. Since this is a remote meeting, we can't move to a different room. Commissioners who are recused should remain silent and mute their phones. On to agenda item number 3. So commissioners have received the 4 emergency certificates of need that were issued by Executive Director Ben Steffen, as well as the underlying applications and the recommendations from the Office of Healthcare Quality that each emergency CON application should be approved. All these documents have been posted on the Commission's website. Today, we will take each emergency certificate of need action separately. In accordance with what I said moments ago, I will now recuse myself on agenda item 3A, and Vice Chairman Sargent will chair the meeting for that agenda item.
Thank you, Chairman Pollack. The first emergency certificate of need is confirmation of emergency certificate of need, establishment of a temporary 10-bed acute inpatient psychiatric unit at the temporary remote location of the University of Maryland Prince George's Hospital Center at University of Maryland Rural Medical Center, docket number EMH2016039. Are there any questions? If a commissioner has any questions about this emergency CON, Paul Parker is available to answer them. So we can start off by, does anyone have any questions on this one for Paul?
Hi, this is Commissioner Boyle. I do have one question.
Sure.
I think all of these look, reasonable, but I do question, because we don't get into that, will there be sufficient staff for these expansions?
So we have Paul Parker's here, and also I should have mentioned, I apologize, Commissioner Boyle, Dr. Trudy Hall, who's the site executive for the alternate care site at Laurel, is on the call, and she might also be able to answer that question.
Mm-hmm.
This is Paul Parker. Can you hear me?
Yes.
Yes, sir.
Yeah, I think that all of these applicants for emergency certificates of need, have clearly incorporated into their planning for these projects plans for staffing the beds. Beyond that, I would ask Ms. Hall to provide any comments she would like to provide here in response to, the detail as far as plans for staffing this psychiatric unit.
This is Commissioner Bandari. I want to echo what Commissioner Boyle has mentioned. Actually, I heard from the patients there some concerns about the care, and I myself contacted Laurel Regional Hospital, and from their staff, I got the answer. We have agency nurses. That's why there has been some issues with the patient care. So I completely agree. This need to be looked into because this hospital was closed, open for COVID and take care of patients, so they should have adequate staff. Thank you.
Good afternoon, Commission. Can you hear me? This is Dr. Trudy Hall.
Take off your.
Yes, Dr. Hall.
Okay, great. Thank you. So for the 10 inpatient behavioral health beds, we are staffing through Maxim agency, and we have already staffed for that unit, and we admitted patients, started to admit patients last night. So we have psychiatric nurses, we have techs, we have psychiatric social workers, and we have the psychiatrists that will be providing on-site care, and then we'll be supported with telemedicine along with psych evaluators. We already have a psychiatric infrastructure, ambulatory and ED to that facility when we transitioned. So we just added on additional services to our ambulatory practice that we have there on site. So we are fine with our staffing for the 10 beds for behavioral health at Laurel. Regarding the staffing for Laurel 345, we have been increasing the staffing. As everyone knows, this is a fluid process. We have staff that call out, as any hospital system. We have staff that have had to be quarantined. So we are, like every single hospital in the state through the COVID crisis, have had to be adjusting our staff and working with our staffing partners. Again, a lot of it is nursing as well as respiratory therapy to be able to handle the pandemic. This is also through Maxim staffing agency and has been supported by the state for our staff for Laurel 345 as well as the behavioral health unit. And we do have quality metrics that we are monitoring under our infrastructure of Prince George's Hospital System. And we have data that we're following and we're sharing with our staff as well as with our clinicians as we are increasing our numbers. We are almost, we've been in the 90 patient number range for the last 2 weeks. And we are getting patients from throughout the state. And we are onboarding additional nurses every single week as we're dealing with some of the crisis that all hospitals are facing across the nation. Any specific questions from the commissioners?
Are there any additional questions? Thank you, Dr. Hall.
Okay, no worries, and we really appreciate the support from this commission to meet this emergent community need. We know a lot of our emergency rooms are now seeing overload of behavioral health patients, and this will hopefully prevent our inpatient units that are not COVID from actually having the risk of infecting the staff and other patients. So again, this will hopefully help to address this urgent pandemic.
Thank you. Do any other commissioners have any other questions, either from Mr. Parker or Dr. Hall, or any discussion? If not, can I get a motion to confirm the emergency certificate of need that was issued to UM Prince George's Hospital Center at UM Laurel Medical Center?
So moved.
Second.
I heard Commissioner O'Connor. Who is the second, please?
I think it was Commissioner Boyle.
Commissioner Boyle? Thank you, Commissioner Boyle. All in favor? Or I'm sorry, is there any additional discussion? I apologize for that. I don't hear any additional discussion. So all in favor?
Aye.
Any opposed? Okay, with that, we can bring back our imperious leader. I'll turn it back to Chair Pollack.
Thank you very much. I really appreciate the commission taking this consideration.
Thank you, Dr.
So thank you very much.
Dr. Hall.
Appreciate your support.
Thank you, Vice Chair Sargent. The second emergency CON that's before us for confirmation today is the approval of an emergency CON for Atlantic General Hospital, establishment of up to 16 additional inpatient beds at Berlin Nursing and Rehabilitation Center. If a commissioner has any questions about the emergency CON that was issued to Atlantic General for up to 16 inpatient beds, Paul Parker is available to answer these questions. Are there any questions for Paul?
And this is Marcia again. I guess what I didn't express it very well, but for each one of them, and it was very extensive, the last one, I appreciate that. And maybe this is a question we have. It would be nice to have some kind of brief statement that the staffing is going to be sufficient, that they know they have the right, the correct trained staff.
Paul, do you have a comment on that? Do we have any information on that?
No, that's not an issue that's specifically addressed in the request for an emergency certificate of need. They don't provide us with a detailed staffing plan for the project.
Nor do we ask for it.
No, no.
Right.
I guess, should we ask for it? Is what I'm trying to say.
I'm not sure in the context of the emergency CON, we can. I guess the, thinking about it from the perspective of the person building the emergency beds, you have to move one step at a time, right? And you can't wait till you have the staff in place before you get the beds. You have to have the beds in place to put the staff in place. You can't put the patient into the bed until you have the staff. That's certain. And I think the responsibility for the oversight of that piece is that's on the licensing end. That's OHCQ. But in none of our CONs have we ever asked for staffing to be in place before we've issued a CON. So it's a matter. I mean, obviously you need the staffing, but it's a matter of the chicken and egg question.
Thank you.
Paul, anything to add to that? Is that is that a fair answer?
I think it's accurate.
Yeah. Do I have a motion to confirm the emergency CON for Atlantic General Hospital?
So moved.
Commissioner Sargent.
So Commissioner Sargent and Commissioner Dordan. Any discussion? Any further discussion? All in favor?
Aye.
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 Any opposed? The emergency certificate of need issued to Atlantic General Hospital to establish up to 16 beds is hereby confirmed. The next emergency CON before us is the confirmation of approved CON for the Johns Hopkins Surgery Center series establishment of one additional operating room at Green Spring Station Surgery Center. Does a commissioner have any questions about the emergency CON that was issued to Hopkins for the surgery center at Green Spring Station? If not, I'll just note that I think this is the first time that we have issued a CON for an ambulatory surgical center operating room under the emergency guidelines. Theory being that we can potentially move cases from an operating room at the main hospital out to the surgery center to free up the staff and capacity at the main hospital to deliver care to COVID patients. Obviously the ability to keep that operating room online after the the state of emergency expires will be dependent on the demonstrated volume moved from the main house to that surgery center, and that there are potential GBR implications of that type of a move. And Paul, I believe we talked about this earlier, the HSCRC is aware of this and monitoring, correct?
Yes. I would like to just say that we have had some discussions with the hospital about the need for this additional operating room, and they did note some things that they probably should have noted in the request, but you won't see it there. They are planning to repurpose some surgical recovery space at the main hospital in order to provide, some additional inpatient service capacity. This was a contingency plan that they had in place in the spring, and they did not need to implement it given the COVID-19 patient demand that they saw. But when we talked to them last week, they were already at a level where they were fairly sure they would need to implement that plan this week, actually, is what they told us. So they may have already implemented that plan. So that's a key factor in why they wanted to do this project. The other is the reluctance that they found among patients to go to the main hospital for outpatient surgery because of the COVID-19 pandemic emergency, and greater willingness to go to an ASC setting, more comfort with that setting. That was a second reason for the project. And they confirmed for us that they really don't have enough free capacity in the existing operating rooms at Green Spring to accomplish those objectives, that they would be pretty booked up if they tried to do this with the existing operating room capacity. So that was why they needed to equip this additional operating room.
And is it their intention to keep this online at the end of the pandemic, or did they not state?
They will have to get a regular certificate of need under current law to add this. So that will be a decision they have to make after the pandemic emergency is over, whether they want to just relinquish this, and in which case they would not use that operating room and would basically use it for storage or for other purposes until such time as they needed it. But they would have the option within a certain amount of time under our rules to apply for a regular certificate of need.
Thank you, Paul. Any other questions for Paul? Hearing none, do I have a motion to confirm the emergency CON that was issued to Johns Hopkins Surgery Center?
So moved.
Ms. Commissioner Sargent, so moved.
Was there a second?
Second.
Second, Commissioner Boyle.
Yes.
All in favor?
Aye.
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 Any opposed? The emergency certificate of need issued to Johns Hopkins Surgery Center to establish one additional temporary operating room at Green Spring Station Surgery Center is hereby confirmed. The final CON that's before us for confirmation today is confirmation of an approved CON for establishment of a 16-bed intensive care unit for COVID-19 positive patients at the alternative care site and temporary remote location of Adventist Healthcare, Inc., doing business as Adventist Healthcare White Oak Medical Center at the former site of the Washington Adventist Hospital in Tacoma Park, Maryland. If a commissioner has any questions about the emergency CON that was issued to Adventist White Oak Medical Center's remote location and alternative care site in Tacoma Park to establish a 16-bed intensive care unit, Paul Parker is available to answer those questions. Are there questions for Paul? The awkward Zoom silence. If not, do I have a motion to confirm the emergency CON for a 16-bed ICU that was issued to Adventist Healthcare White Oak Medical Center's remote location and alternative care site?
So moved, Commissioner Thomas.
Commissioner Thomas, second by,
Boyer.
say again?
So moved.
Commissioner Boyer,
Yes, second.
second. Any discussion? All in favor?
Aye.
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 Any opposed?
Aye.
Dr.
Okay.
Pollack, this is Howard Sellens. I'll just express our thanks to Paul and also to Sue Ellen Weidman, who had substantive discussions with Rob Jepson and Andrew Nicholas and others about this need, and we appreciate very much the work that was done.
Thank you, Howard. The emergency certificate of need issued to the alternative care site and temporary remote location of Adventist Healthcare is hereby confirmed. All right, moving on. Agenda item number 4, selected episodic spending among Maryland's privately insured. So since the launch of the consumer-centric price transparency initiative, Where the Cost has had 3 releases spanning 4 years of the privately insured claims data. Mahi Nagatu, Chief of the All-Payer Claims Database Public Reporting and Data Release, will present the trend report for selected episodic spending amounts covering the 3 study windows spanned. Mahi, please proceed.
Thank you, Chairman Pollack. Can you hear me?
Yes.
Thank you. Good afternoon, Commissioners. Where the Cost Price Transparency Initiative had 3 releases since the launch of the project and is currently in the process to release the 4th round covering 2018-19 data. This presentation will cover spending for episodes selected across the 3 study windows. Next slide, please. You may be very familiar with this slide from past Where the Cost presentations, so I'll go through it very quickly. Data for the 3 releases was sourced from the MCDB data, which is the Maryland APCD, or we call it the Medical Care Database, privately insured claims data. Study window represents the years of data used for the creation of episodes for a cohort. So we have 3 cohorts, 2014-15, 15-16, and 16-17. Kaiser and ERISA data are not used, not included. And as for the development and production team, it includes MHCC staff, Signify Health, and DLH Corp, which is SSS, for the execution of the software and the development of the website. Next slide, please. 4 episodes, that is hip replacement, knee replacement, vaginal delivery, and hysterectomy, are selected for this report, as these are episodes part of the first release and common across the 3 study windows. When looking at the statewide average episode cost, we can see that hip replacement costs declined and vaginal delivery observed a 7% and a 3% increase for 2015-2016 and 2016-2017 study windows, respectively. Whereas the change in the average cost for knee replacement and hysterectomy episodes across the study window is inconclusive, as we see an increase in the cost for 2015-2016 and then a decline in 2016-17 for knee replacement, and we see a slight decrease in 2015-2016, but then an increase of 5.7 in 2016-2017 for hysterectomy. Next slide, please. Next, we will look at the cost breakdown by hospitals. Cost for episodes on the Where the Cost website, and here is risk adjusted, which means the cost is adjusted to reflect the severity of the episode or the illness burden of the patient mix. To accomplish this, the grouper, the Prometheus grouper, looks at the patient demographic and comorbidities, and this is identified from the diagnostic codes from the historical claims data. So for instance, for the study window of 2015-16, 2014 data is used for the look back. Next slide, please. So when we look at hip replacement cost, we can see that, so first of all, just a note, this just includes hospitals that are qualified for reporting across all 3 study windows. So Adventist Healthcare, so a decrease of 5.8 in 2015-16, and then an increase of 15.8 in 2016-17. Sinai obviously has the highest cost among the hospitals and across study windows, and also saw an increase of 4.8 in 2015-16, and then 7.5 in 2016-17. Anne Arundel Hospital had a decline for both subsequent study windows. That's the second one. Next slide, please. Similarly, for knee replacement, we can see that Adventist, MedStar Southern, and Sinai had relatively higher cost among hospitals across study window. MedStar Union had a decline in cost of 8.7, followed by a 2.8 in the subsequent study windows. Frederick Memorial Hospital had an increase of 15.8 in 2016-17 from the prior study window, that is 2015-16. Next slide, please. So moving on to vaginal delivery, I just want to point out that this chart you're looking at is not the correct one, so I'll just provide you a breakdown of the reading from the slides that I'm looking at. However, the breakdown for vaginal delivery mirrors the statewide trend that we have seen in slide 3. So just as a reminder, for the statewide average cost for vaginal delivery, there was a steady increase. Similarly, at the hospital level, we can see increase across hospitals, except for MedStar Hospital and Meritus Medical Center that had seen a 2% and above decrease in cost in 2016-17 study window. MedStar Southern saw the biggest increase of 18.5 and 16% for subsequent study windows. Next slide, please. So lastly, for hysterectomy, we can see a mix of changes in the study windows, in the cost across the study windows. Most of the hospitals saw a decrease in cost in 2016-17 cycle, particularly Adventist and Hopkins had a decrease of above 17%. Howard County General Hospital. Go ahead, is it a question?
I'm sorry, I did have a question, but I can also wait. It's sort of up to you.
So Howard County General Hospital, the change remained steady with a slight decrease of 0.2 and 0.7 in subsequent study windows. Next slide, please. So when we look at the episode volume, we can see an increase of the total episode count as we progress through the study window. So what does an increase in episode count mean? It means that if we have more episodes, we are able to report more hospitals. And the increase can be partially explained by the first one being the refinement of the study window. By this, I mean the standard study window is a 2-year study window. And what it looks at is all the episodes that started and ended within that period. So the way we modified it is after the release, the first release was that to look at all the episodes that ended within that 2-year, regardless of when they started. So which means, for instance, for episodes like hysterectomy that had more than 30 days of look back, we were able to capture that by using 2000, like if we're referring to a 2015-16 study window, we were able to look into the last quarter of 2014 and be able to look at the complete episode for 2015-16. So that way we were able to capture more complete episodes. The second reason is the episode grouper alignment with the new procedural and diagnostic codes. With the new ICD-10 code, the new versions of the grouper were released, and that also helped in increasing the episode volume. The other one, more significantly, is the MCDB data submission and quality check improvement. So for the next few slides, I'll just go over the episode count through the 3 study windows. Next slide, please. So just looking at hip replacement and the changes from 2014-15 all the way through 2016-17, we can see there's an increase in count and volume coming in from other counties. In 2015-16, we can see counties like Calvert, Comico, and St. Mary's having some volumes, and then in 2016-17 we have episodes coming in from Queen Anne's as well. there was an average of 15% increase in volume in the other counties that had an episode in prior periods, which means in 14, 15. Next slide, please. Similarly, for knee replacement, we saw an increase of 177% of the total episode volumes since 2014-15. So now we have representative episodes from all counties. Next slide, please. Vaginal delivery being a common episode, there has always been a good volume. And it's partly because the study window modifications has a minimal impact on the completeness of the episode, as the look-back window for vaginal delivery is just 3 days, unlike hysterectomy and knee replacement that had like a 30-day look-back window. Next slide, please. And for hysterectomy as well, we see more episodes coming in from Eastern Maryland as we progress through the study window. Next slide, please. And lastly, this is in the 2016-17 data, we were able to incorporate birth month and year in the input file. So we were able to produce this breakdown by age group. So the first table shows the episodes that we have selected for this report, and among the just looking at hip replacement, we can see about 13% of the episodes comprise of the age group below 50, and only 6.3% of knee replacement comprise of the age group below 50. Whereas 12.3% of hysterectomy episodes were done for patients below the age of 40. For the new episodes, that's the table that you see below. These are new episodes that we included in the 2016-17 study window. We can see 8.3% of the bariatric surgery episodes were done for the age group below 30, and 23.7% of the C-section episodes were done for the age group below 30 as well. So I think those are some of the numbers that stood out. Next slide, please. So lastly, as a summary, we have seen that the statewide average episode cost declined for hip replacement episode, and we've seen an increase of the statewide cost for vaginal delivery. But however, for hysterectomy and knee replacement, the results were inconclusive. We also have witnessed that improvement of the MCDB data submission and quality check contribute to the increase of the episode volume. As a next step, we are, as I said, we'll be processing commercial 1819, and we'll be using the demographic distribution that we have seen just to inform the Where the Cost consumer education campaign. Just so I could take like a few minutes to answer to Commissioner Dr. Bandari's earlier question on why the traffic has declined. This is specifically for the Where the Cost. As Ben mentioned, we have the Hatchers. We're working with the Hatchers group, and this is a fairly new contract that started 3 months ago. And what we are doing differently this time around is that we used the last 3 months to research and understand how Marylanders get their health and particularly health cost information. So in the first month, which is in October, we ran a programmatic ad that is run on non-social media based platforms and collect the data. So this is for just to see a reactionary residents to see how they get their information. So this is just exclusive of any social media campaign platform. In November, we were able to run a Google search ad. So this is for proactive residents that go on Google and search for healthcare cost. So, and then we were able to gather data in that. When I say data, it's traffic and engagement. And finally, we run similar campaign in December on social media platforms. And from the last 3 months, what we have found is that Marylanders do not get their information from social media. And we have seen that the most successful platform is Google search, and these are like proactive residents that go out and look for information. So that's why you've seen a decrease in December, because we have focused our resources on running that the campaign on social media alone. So this was just to understand how Marylanders shop. So going forward, we are going to come up with a customized approach to use a non-social media based campaigns and programmatic ads. So I just wanted to add that to the previous discussion. Thank you. That concludes my presentation.
Thank you, Mai. Mr. Sargent, I believe you had questions before.
I did. Thank you, and it's a very interesting presentation. Thank you for putting it together. I had one question. Looking at the bar charts with the costs, like slides 5 or 6, any one of them. Is there a way to get a version of that with breaking out ones covered by the costs covered by the global budget with professional costs not covered by the budget in each of those bars? It would be interesting to see. There doesn't seem to be a clear pattern from year to year as to who goes up and who goes down in terms of cost. It would be interesting to see how much of a contribution to each of those bars the global budget covered costs versus professional costs were.
So I'm not sure. So we have a breakdown of the by type of services. So we can look at this by professional services and inpatient services, and we can also look at based on where the procedure was triggered. So I'm not sure if that will have a marker to say this is global budget or not. So I think we can, just by looking at the inpatient triggered procedures, we might directionally say that those are under GBR, but I don't know if that will be correct.
So if I could interrupt, Mahi.
Sure.
I mean, I think that probably it would be good enough to say, and I think we can do this very well, is to break out cost by inpatient, hospital outpatient, both of which would be subject to the global budget, healthcare professional, the practitioner charges, for most of these, there would be physician surgical services, anesthesia, and a bit of, in some instances, rehab, and then drugs. So yeah, I think we can do that.
That would get you there. I think that's right.
I might add, just as a sort of socializing element, that Care First is also experimenting with this particular grouper. We look forward to working with Brian Wheeler and his team further on their progress as well, because this particular methodology, there's a number of competing approaches, but this is one that we think is attractive and more transparent than many of the products out there in terms of making information available on how it's built, which is critically of interest to the provider community to know how this is being scored.
Thank you. I had one other question, if I don't want to monopolize the. My question was simply, it looks like the improvement of data contributed to the increased episode volume. Do we think it was the cause, or do we have some reason to believe that all of the volumes of all of these surgeries are increasing in all the jurisdictions, even after adjusting for that? Like I looked at those numbers until I got to the data. I was like, holy cow, we're getting a lot more knees and hips. And do we think that pretty much the adjustment in the data gets rid of the increase in volume overall?
Hard to imagine that there's been that much of an increase in the birth rate when we're measuring vaginal deliveries.
Yeah, especially in 2020. Well, 2020 is baked in, I guess. It'll be 2021 we'll have a drop.
Mahi, do you have any thoughts on that?
No, I agree with you, Dr. Pollack. I think mostly the modifications that we did with the grouper, that has a significant help to the change, and especially like modifying the study window. That was very. We were able to capture more episodes in that approach, and the MCDB data improvement also kind of helped in that as well. I mean, through time, we'll definitely will see an increase, but I think most of the reason or the justification for the increase in volume is definitely those three reasons we talked about earlier. And we'll keep monitoring, especially since especially when it comes to the grouper itself. Sometimes there are some codes, procedure codes that are not well captured, and that we have seen, especially when we transition from 14-15 to 15-16, we have seen a lot of codes that were not appropriately grouped. So that really contributed in the increase of the volume of episodes. So we have to keep an eye on that and make sure that we use the latest version and look out for any additional codes that are available to make sure that we capture more procedures, and which means more complete episodes.
Thank you.
Thank you, Mahi. Other comments?
Commissioner Boyle, I'm just curious, will the Kaiser claims be included going forward?
That's a Ben and Ken question.
Yeah, I could jump in here. So we are working with Kaiser to have them report the fee-for-service equivalents for professional services and also for pharmacy. Right now, Kaiser is not providing that information. We are working with other states as well, where Kaiser report this information to the APCDs. So we had a meeting with Kaiser like a few months ago, and it was a good meeting, but they're worried that the information that they provided to the MIA would not tie out to what they will report to the MCDB. So that discussion is ongoing, but we are pushing Kaiser to actually do this because they are a very large part of the ACA market here in Maryland. So we continue to work with Kaiser to really provide that information.
Thank you. Other questions? Hearing none. Thank you, Mahi. The agenda item number 5 is a legislative update. Tracy DeShields, Director of Policy Development, will provide an update on the ongoing legislative session. She'll provide an overview of bills with hearings scheduled over the next few weeks and describe the Commission's staff's recommended positions on those bills. Commissioners will then have an opportunity to discuss the bill positions that staff recommends and determine the Commission's position on those bills. Tracy, please proceed.
Thank you, Mr. Chairman, and good afternoon, Commissioners. I want to make sure you can hear me. Are you?
Loud and clear.
Great, okay. So I'm going to provide an update on the legislative session so far. A few of the slides are repeats from last month's presentation. I'll go over those pretty quickly, but I included them as a refresher with regard to session. But my focus will be on the session generally and legislation. Next slide, please. So generally, I'm going to cover the role of the Commission during session, dates of interest, position paper development, types of legislation that we're seeing, and the 2021 key changes for the legislative session. Next slide, please. So generally, the role of the Commission plays is one where we educate and build strong relationships with the legislature. You are a source of information for them and others that respect the commission and want your opinion and often want you to weigh in on various issues. Some of the predominant issues for this legislative session are around telehealth, health information technology, and health disparities, interestingly enough. And I think probably given the climate that we're in and the pandemic, some of those issues are being driven from that perspective. Also, up this year, obviously, will be the budget for the commission, and just to provide general information to legislators around areas of expertise. Next slide, please. So a couple of dates of interest, more than interest actually, for the commission. January 27th, there'll be a bill hearing, 2 bill hearings actually, on telehealth. And one of the main bills is Senate Bill 3 and House Bill 123. They are both being heard in respectively in the Senate committee, which is Finance, and the House committee, the Health Government Operations Committee. So I will talk more about those bills later because there's a lot of information and there's been a lot of activity around those bills. But I wanted to note the date because it is significant, and the commission will be weighing in. But we'll talk more about that, and Ben and David will add to that discussion. February 15th is the budget hearing in both the House and the Senate for the Health Commission. It will actually be a joint budget hearing this year. And part of that has to do with the fact that session is virtual. And so just about everything is being done over Zoom. And that includes the bill hearings and briefings, et cetera, for the commission, for the legislature. Next slide, please. So this year, session's very different. So normally we would, the legislature will be meeting in person. Much of their work, probably 95% of it, will actually be taking place virtually, online. Their bill hearings are all online, meaning which impacts sort of the process of things. Normally, to develop position statements, to develop positions, even try to work out issues on bills, we have pretty good amount of time. Things move very quickly for the legislative session because it's only 90 days, but generally we have a few more days than we're given now. So we will be probably reaching out to you a little more frequently than normal in order to get some feedback on bills or possible positions on bills. So during the session, some of you might know, the newer commissioners may not, but we do a legislative policy call each week. The first call will be held next Friday, January 29th. The call is at 8 o'clock. You should have received a calendar invite for that call. And during that call, we will go over bills that will be up for bill hearing. And we have to do it now in a 2-week period just because of the timing with regard to bill hearings and when information needs to be sent to the committees. So we're almost running 5 days ahead of schedule with regard to providing information to committees on bill positions and providing them with testimony and position statements. So this week, this particular presentation will count for one of our discussions on bills and bill positions, as well as update you on what has occurred so far. So, and if you do not have a calendar invite for the Friday calls, please let Dee or myself know, and we'll make sure to send you the calendar invite. Next slide, please. This slide just generally shows the process for MHCC with regard to developing a position on a bill. Staff will usually generate a position and provide a recommendation on that position and provide a reason for why a particular position should be taken, whether we should support, whether we should oppose, provide a letter of information. So generally, I think we do very few oppositions, as I understand it, and I think the alternative would be to provide a letter of information, but perhaps a strong letter of information. Next slide, please. This slide just simply lays out the types of legislation and executive agency roles during the legislative session. This is something you can just read over. It's just there for your general information. Next slide, please. Okay. Again, as I mentioned, the General Assembly has implemented procedural changes for the 2021 legislative session. Due to these changes, we have to have written testimony, names of witnesses to our Office of Governmental Affairs at the department 3 days ahead of the bill hearing date, which for us means we're really operating 5 days ahead of schedule. Normally, position statements and witness identification, you could almost do it up until the day before a bill hearing, but they're not allowing that this time just because of the fact that everyone is working remotely and online, and I just think logistics are very difficult. And then each week, myself, along with Sade, we meet with the other legislative liaisons within the health department. We go over our bill positions so we kind of know what's going on broadly across the department and broadly with regard to various issues that are being heard in the legislative session. So we'll start Monday, January 25th in the afternoon. So it's just general information for you on just some of the process. I did, next slide, please. Next slide.
I believe that's the last slide.
That's the last slide. Okay, thank you. Okay, all right, so now I'll just proceed to go over some of the bills impacting the Health Commission. The first week of session started January 13th. So last Wednesday, we did weigh in on 2 bills. That one was heard the House bill was heard last week and the Senate bill was heard this week. The bill that the commission weighed in on, we provided a letter of support. It's House Bill 224, Senate Bill 262. It had to do with a study of a common information technology platform for the health occupation boards. This bill was put in last year. The issue around trying to standardize the information technology platform for the licensing boards has been around for a number of years. We provided a letter of support stating that standardizing the information platform that the boards have would actually provide ease of getting information from them, data, and actually would be very useful for them as well. So we did provide a letter of information on that. Also, a bill of interest is one where this involves the closure of Hartford Memorial Hospital and its relocation. The bill, it's House Bill 390, would require the University of Maryland to conduct an economic impact study with regard to that particular closure and then the relocation of that health facility. Then House Bill 368. This one would create a task force on oral health in Maryland. This has come up a number of times, and I believe there have been numerous task forces over the years looking at oral health. In looking at the bill, it looked like it was more expansive than Medicaid, but during the bill hearing, the focus was on Medicaid and looking at coverage on oral health and access to oral health by those on Medicaid services. So those would be the general bills for last week and this week. This week coming up, there are several bills being prompted. The bill that I was talking about related to Task Force on Oral Health is House Bill 368. That's the answer. So there are several bills coming up this week, the week of January 25th, that interestingly enough deal with health disparities. And so the first bill is House Bill 309. We do have a recommended position for the commission. It would be a letter of support. This bill would require the Office of Minority Health and Health Disparities, along collaborating with the Healthcare Commission, to develop a policy report on race and ethnicity, including information on race and ethnicity in the report on health disparities. And then it would require periodic updates for that. So that's that bill, and the recommended position is a letter of support. Then there is House Bill 78. This is the Maryland Commission on Health Equity, the Shirley Nathan Pulliam Health Equity Act of 2021. The recommended position is, again, a letter of support. This particular bill basically redefines the Maryland Commission on Health Equity. The membership would include essentially the governor's cabinet. So like all the health secretaries across state government would be on this commission. It also would require CRISP to participate on the advisory committee, as well as maintain data that includes race and ethnicity with regard to health disparities. And then the last bill up is House Bill 28. It's Public Health, Implicit Bias Training, and the Office of Minority Health and Health Disparities. First, this would require the Office of Minority Health and Health Disparities to create a health policy report that includes information on race and ethnicity as it relates to health disparities, again, in collaboration with It also would require health professionals licensed through the health boards to take a bias training, and they have to present proof of that upon renewal of their license. So those are the 3 bills, and the recommendation again on that one would be a letter of support. For now, I would like to just skip over the telehealth bill, and I think there was just one more bill. That's up next week, or actually it's up the first week in February. It's House Bill 416. It has to do with assisted living programs, memory care, and Alzheimer's disease unit regulations. So this bill would simply require assisted living programs where they have a memory care and Alzheimer's disease unit to would require the Office of Healthcare Quality to come up with regulations similar to those that they have for the nursing homes and their memory care units to put in place. The recommended position on this one would be to take no position, since it does impact a sister agency. So I wanted to bring that to your attention. And then I'd like to go back to House Bill 123 and Senate Bill 3, the telehealth bills. And Ben, if you could please provide some background and detail on what's been going on with that bill, since it's a lot of activity, and David as well.
Thank you, Tracy. First off, I want to recognize the work that David and his entire team has done in fostering telehealth over the even before the pandemic, but certainly throughout the pandemic period. So 123 is a bill that really represents, I guess I would characterize it as a provider consensus bill that would, broadly speaking, memorialize many of the waivers that were put in place in the pandemic period, as well as establish parity for telehealth with face-to-face visits. And it's important to recognize a couple things where there's a lot of agreement on certain elements of this, particularly as it relates to expanding the scope of telehealth services. There is a concept largely developed in Medicare called originating sites, which are the location of the patient, and the distance site, which is the location of the treating provider, that was very restrictive pre-pandemic. It wasn't employed by commercial payers nearly as widely as it was broadly applied uniformly in Medicare, but it did lead to the constriction of the adoption, because it meant that a originating site was typically for patients a healthcare facility, which automatically crossed out patients' homes in almost all cases, and also required the distance, the treating provider, the distance location to be a healthcare facility. Those were waived, which without thinking about this, you might not realize how important it is, but by taking those requirements away, all sorts of technologies suddenly became plausible, some better than others. And that was fine during the pandemic in most people's judgments. But what that meant was, who's to know what's in a patient's home in terms of technology? And in many cases, the technology that was available was audio only. And in some cases, providers' locations as well. So audio only diffused during the pandemic, particularly in the early phases. We think it's diminished somewhat, but there is a sense that, especially felt strongly in the provider community, that it ought to continue. The payers differ, but where there is really strong disagreement is in the arena of what it should be, how it should be reimbursed. We've talked to payers and providers together. We've talked to payers by themselves, and we've talked with providers by themselves. And we've concluded that really, and David's team has done a remarkable job of surveying where the, broadly speaking, the industry stands, generally the technology stands. And what we've concluded is that it's really too early yet to come out with hard and fast policies on reimbursement. And we are offering what we hope would be considered by the sponsors friendly amendments that would do a couple things. First off, say that payment levels or services would continue as they are defined in the pandemic period. That is, payers would continue to offer what they currently do through 2023. And in the meantime, another element of that amendment would be that MHCC would conduct a systematic evaluation on the technologies being employed, patient preferences, cost effectiveness, and appropriateness on the part of both telehealth and audio only, in what settings they would work, and come back with the recommendations on those issues, specifically as it relates to payments and as it relates to the appropriateness of telehealth services for certain types of care. I think we can get agreement, although no one has agreed to at this point. There is recognition, I think, that we may be moving too quickly on the part of some in the legislature, but there is interest in preserving what we have in terms of scope of service until better and more complete information can be garnered. So that would be our position. David, do you want to add some meat on that skeleton of what I've laid out?
Sure. Thanks, Ben. Again, good afternoon, everyone. So it is interesting that it took a pandemic to bring telehealth to the forefront of healthcare delivery. I think Ben noted that the commission has been working probably for 10 years before the pandemic to try to diffuse telehealth. And the issues that we're grappling with now didn't just emerge. They've been hanging out there for quite a long time. And the industry just wasn't really ready to tackle them. And now under pressure, we're trying to solve a lot of policy challenges in a snap of time. I'm leaping ahead to the fall. Staff convened a telehealth policy work group. And what this work group did was look at key policy areas that to some extent are discussed in the bill. We had more than 70 stakeholders representing payers, providers, and consumers that participated. And there was a lot of support for the kinds of recommendations that Ben mentioned that the amendments note, which largely relate to really allow coverage and reimbursement that's being offered today under the waivers that are established both at the federal level and in the state by executive order to continue for a period of time in which the MHCC would be able to complete, as Ben mentioned, a more thorough evaluation of telehealth, and then come back with solid recommendations. And the other, which really didn't meet with much opposition in the work group, was to remove restrictions on locations for patients and providers. So there was some general consensus there as well. But I think what we've heard from the stakeholders in general is that allowing for the continuation of what exists today to continue onward as it relates to audio only, as fitting under the definition of telehealth, seemed like a wise and practical decision in the judgment of many of those providers. We don't yet know how the amendments will be received, as Ben mentioned. We've not heard a lot from the payers and providers, but we'll see how that plays out. So I would pause there and see if you all have any specific questions, and happy to fill in where necessary.
David, this is Commissioner Thomas. When you said adjust restrictions on location, can you clarify what that means?
So the work group was saying it shouldn't matter where the patient is, and it shouldn't matter where the provider is. If it's a provider who is a practitioner who's licensed to provide care, and it's permitted by their licensing boards, then it shouldn't matter who with the provider type. And so essentially, if they can bill for it, they should be permitted to provide their services and bill for it. And the location of the patient, at one time, it was required that the patient be in a certain setting to receive telehealth. And now the expansion allows the patient to be at their home or any other location.
The patient can be in the barber chair, yes.
Well, we wouldn't put them in a chair. We have a special private room.
Oh, very good.
Private room could be.
I was going to say you might want to advise the barbershop participant about privacy issues.
No, I say, no, in all seriousness, we actually have renovated space for privacy purposes with access to TVs and internet. So if that space is a legitimate space for that kind of consultation,
yeah, outstanding.
That would be great. I'm just making sure that that is in fact the case, because we're investing money in the renovations.
Outstanding. But there is one other element, Dr. Thomas, you bring to light, and that's access to broadband. It's not always consistent, and there's a lot of old technology out there that exists. And what we have found historically is that technology vendors were really slow to modernize solutions to the software that would support telehealth. And there was a lot of one-offs and a lot of dual entry and difficult integrations amongst providers. And what we've seen industry-wide in the last 8 to 10 months is a rapid diffusion of more advanced software that allows for seamless integration, but it doesn't address the access issue to broadband, which can be sporadic in places, or in some cases where consumers use outdated technology to try to access the use from a phone. I won't even call it a smartphone, more of a flip phone, where in a lot of those those mobile device carriers are planning to discontinue support for those kinds of phones in 2021.
But just to be clear, many of the EMR technologies, there's a lot of technology being developed that links directly to the existing EMRs that will allow providers from within the EMR to send a link to a cell phone, a smartphone now, not a flip phone, but a smartphone, which is 95% of the phones that are out there, that requires no additional broadband capabilities, simply requires cellular access. And I think that within a year or two, you'll find that the overwhelming majority of the population will have access to a smartphone, a regular smartphone. All it has to do is have a camera on it. So if you can FaceTime with your friends and relatives, you can do a telehealth visit with your provider in that situation. The challenge has been that much of that technology to date, when on the provider side, it was HIPAA non-compliant. In the context of the pandemic, we were allowed to use it. The HIPAA compliance mandate was waived, but the new technology being developed is not only HIPAA compliant, but also smartphone friendly. So all of that broadband necessity is likely to go away in the coming year or two, and the ability for the patient for the overwhelming majority of patients to access it will be dramatically increased.
Thank you.
Dr. Pollack, this is Commissioner Akintate, and just this is a curious question, not to try to put forth additional barriers, but are we recommending or doing anything to basically meet some basic competencies for providers in terms of telehealth provision, to patients? I know we're spending a lot of time in terms of patients and access broadband versus non-broadband, and I like the example from Dr. Thomas in terms of the environment the provider maintains while they're providing the service, but are we recommending some guidelines or at least just some basic competencies for providers in terms of delivering care via telehealth?
So to my knowledge, we haven't. David, you can step in.
Sure, that's a great question. Staff has done a lot in terms of to try to educate, make resources available, and diffuse that educational material to provide healthcare practitioners as it relates to best practices on telehealth. We have what we call a resource site, Telehealth Resource Center, on our it's a web page on our website, which includes a lot of information related to the best practices, Commissioner, that you are sort of referring to. There isn't a structured program out there on best practices for providers to use telehealth, but we've talked about that internally a great deal and think that we want to keep working to try to come up with a standardization. Even the work group in the fall mentioned how this could be important, but in terms of prioritization, you know, there's value in doing it, and it's just the timing. And I would say historically, prior to the pandemic, that was one of the reasons telehealth wasn't so embraced consistently across healthcare providers, because there's workflow disruptions, there's a whole different approach to how you engage a patient when it's virtual, and it was to some extent foreign to a lot of healthcare providers. So the short answer through that long answer is staff is working on that in collaboration with stakeholders.
To Dr. To your point, I think you're talking more about as a requirement of licensure. I'm not aware of any state that's doing anything like that just yet as part of, you know, NCQA does a lot of certification programs. So I wouldn't whisper that too loud because they may get those ideas rather quickly. I would note that NCQA has recently taken, you know, an interest in this, and former Commissioner Dr. Barr has had a couple of discussions with David and me about, you know, what we're doing. So I think the idea that there would be certification programs is not unreasonable.
And we have heard that anecdotally that some medical schools are now building in their training the use of telehealth.
Well, I think before we jump to things like certification and regulation of things like how to maximize the efficiency and the effectiveness of a telehealth encounter, that developing a science around it is probably important. Developing educational programs is probably important. And that work is often the lane, if you will, of professional societies, of medical schools, and of other educational organizations. And I think that as a commission, we can encourage those organizations to start to look at the most effective ways to teach good and effective telehealth communication to providers. I think prior to regulating it, we need some understanding of what exactly it is we would regulate. We can't mandate a course that doesn't exist yet, and we can't mandate a course that hasn't been demonstrated to be effective yet. But we can certainly suggest that such courses and such science be developed. Dr. Akintate, did that address your question, I think?
Absolutely did. Thank you.
Yeah.
And I wanted to say, since I set an objection out to the bill as it was written, I'm okay with the compromise of extending it for 2 years and doing the study. So for whatever that's worth, I'm on board with the compromise Ben just laid out.
That's worth an awful lot. And I just want to extend my thanks and congratulations to staff on working through the challenges posed by the different players in this arena right now, and getting us to the point of a potential piece of legislation that the legislature could act on this year. So we've made tremendous strides in telehealth access over the past year of this pandemic, and it will be very important for us to maintain that access. There was a question in the chat about a public comment period on the bill. That'll be up to the legislature to determine what the public comment will be, not us.
Andy, it's Chip.
Yep.
Can I just make sure that, because I know a number of us did weigh in on this at the request of, or at the opportunity given us to by Ben. What we're endorsing then does include the concept of a telehealth telephone call without visual. Is that correct?
It does, yes, includes.
Okay, fine. Thank you.
And then additional comment was a question about public comment in this meeting, and the answer is no, unfortunately. We're not able to do that right now. All right, anything else, Tracy?
No, that's it for me. And I think we just, for myself, just to confirm that the commission is fine with the positions that have been recommended.
Do I hear any objection from the commission on the positions that have been recommended?
I just have a question. This is Commissioner Thomas.
Yes. Sir.
Hello, Tracy. How are you?
Hi, how are you, Commissioner?
Good. Listen, when we say we recommend letter of support,
yes.
What's the range of things we could recommend? I mean, we recommend to say, no comment. Is letter of support the next level up from a no comment? And is there a level above letter of support?
No, oftentimes a letter of support is a letter of support. So certainly, if you're talking about being able to verbally testify on a bill in support of it, that's the strongest you can possibly be because you're in person. The next thing would be what they call letter of support or written testimony in support. But it's really no hierarchy.
Okay.
For this year, it is a little more cumbersome with in-person.
Understood. And that letter would come under Ben's signature and Andy's signature? How does it come?
It would come under Ben and the chair's signature.
Okay. Thank you very much.
You're welcome.
All right. Thank you, Tracy.
Thank you.
Moving on, Ben, do you have, would you like to share the upcoming activities for the February public meeting?
So the big points are after a hiatus of a month, we will be resuming our presentations of recommendations for certificates of ongoing performance for PCI programs. We expect to have one additional CON action to bring before you. We will be also providing some additional information, we hope, on the Maryland Primary Care Program Track 3. As the commissioners know, we are assisting in funding the project management office. We've recently started to work more closely with them, recognizing that our ability to, we do have to continue to fund them, but we want the commission to be more than a silent partner on this endeavor that's been judged important to the governor and the health department, that primary care be enhanced. And then I think in February, we will have a better idea of what our calendar of bills looks like. We will have completed our budget hearings on February 15th, and we'll provide some insight to you where we think we stand on that.
Excellent. Thank you. All right.
I did want to add one other point. I know I have some backlog on communications with several commissioners. I haven't forgotten them, and these are important ideas that you've suggested. A couple of them do require some conversation with the chair in terms of whether we would take them on. So I haven't forgotten.
Thank you, Ben. So agenda number 7 is a motion to adjourn to closed session and meet with council to discuss MHCC's oversight of acquisitions. Do I have a motion to adjourn to closed session?
So move.
Commissioner O'Grady, second.
Second Boyer.
Second, Commissioner Boyer. All in favor?
Aye.